by Dr. Brownworld, and he said, look, in the last 45 years, there many changes have happened, but I'm only given 30 minutes to speak on that. How it is possible? I said, okay. So now, what we are going to discuss in this meeting is the global Indian burden of heart failure. What is the etiology and neurohumoral activation? In brief, stages of heart failure, how heart failure with reduced ejection fraction is going to effect on the mortality, hospitalization, etc. What are the current options we have got in heart failure? We have got beta blockers, which is foundational therapy for all patients of the heart failure. Recent algorithms in heart failure, clinical trials of beta blockers in heart failure with many comorbidities and others as well. And concluding remark. Now look at the global prevalence of heart failure. It is all over the world that heart failure is bothering the treating doctor and the patient. You see how the incidence of the heart failure is increasing as the age is advancing, as the time is advancing, and this is the projection of 2030. How much heart failure patient we are going to have in future. So this is a quite alarming figure. The Indus study was done to know the prevalence of heart failure, and the estimated prevalence was found to be 1% of the total population. That means mortality is approximately attributable to 0.16 million individual is at the moment. What are the etiology of the heart failure? First is the reduced ventricular contractility by any etiology, be it coronary artery disease, myocarditis, cardiomyopathy. Cardiomyopathy is very popular, especially alcoholic cardiomyopathy, viral myocarditis, peripartal cardiomyopathy, wet beriberi due to vitamin B1 deficiency, idiopathic, and rarer causes of heart cardiomyopathy like your amyloidosis, hemochromatosis, sarcoidosis. There are a number of cardiotoxins, and even the anti-cancer medicine are very notorious like anthracycline, cyclophosphamide, and 5-fluorouracil. Then second number in etiology is ventricular outflow obstruction, that is causing pressure overload to the left ventricle or the right ventricle. Hypertension, aortic stenosis, pulmonary stenosis, pulmonary hypertension. Ventricular inflow obstruction, mitral stenosis, tricuspid stenosis, ventricular volume overload, aortic incompetence, mitral regurgitation, ventricular septal defect, atrial septal defect, anemia, and so many others. Arrhythmia is notorious, particularly if you, even in a younger patient, if the sustained tachycardia, SVT, if it is sustained more than 48 to 72 hours, it can lead to heart failure. Atrial fibrillation is notorious in producing heart failure because we lose the atrial contribution in the cardiac output. Complete heart block. Then we have got diastolic dysfunction, constrictive pericarditis, restrictive cardiomyopathy, LVH, and fibrosis. Neurohumoral activation leads to vicious cycle. That's why it is important. We have to break the chain of the vicious cycle. When there is a myocardial fibrosis, myocardial loss, there is a heart failure due to reduced ejection output, and this this sets in many neurohumoral activation. There is a stimulation of the sympathetic nervous system. There is a renin, angiotensin, aldosterone system. Vasopressin is liberated. Endothelin system is activated, particularly endothelin 1. This is from endothelial wall, endothelial cells of the vascular wall. Now, these things does? They lead to vasoconstriction, and this leads to increased afterload. There is sodium and water retention, increased intravascular volume. All these have lead to increased blood pressure and cardiac work, and this in turn leads to formation of the vicious cycle. And there is a more progressive worsening of the heart failure. There is a more myocyte loss. There is a more myocardial fibrosis. So we have to catch the vicious cycle. Must break the vicious cycle of the heart failure. This is a very common picture. You have already seen it multiple of times. The stages of the heart failure: A, B, C, D. A is asymptomatic, completely asymptomatic, but with predisposing factors. B is asymptomatic heart failure, which has suffered from already pathological changes like previous MI, LV systolic dysfunction, asymptomatic valvular disease, and then C is the symptomatic heart failure, and D is refractory heart failure. The risk factors are many. To name a few: obesity, high blood pressure, coronary artery disease, heart attacks or myocardial infarction, diabetes, sleep apnea, congenital heart disease, valvular heart disease, alcohol use, tobacco, certain medications, etc. Obesity is not simple obesity. Obesity leads to very much inflammatory changes and leads to development of CRP and damages endothelial wall, and there are so many neurohumoral changes in the obesity. So we must know all these things when we deal with a patient. Heart failure, there are two phenotypes of heart failure. We call it now heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, when the ejection fraction is more than 50%, and when less than 40%, we call it heart failure with reduced ejection fraction. Now people are talking also of the mid-range, but I recently attended a CME and they have ridiculed it, and they said, particularly I can name you the one of the researcher, Dr. Milton Packer. He said that there is no difference in the treatment of the heart failure of mid-range and from the heart failure with reduced ejection fraction. So let us completely omit that nomenclature. It is just going to confuse the treating doctor. There is a lot of comorbidities, risk factor with reduced ejection fraction, and much more comorbidities or risk factor are seen with preserved ejection fraction. Just one more point: cardiomyocyte cell death, that is called apoptosis, is present in patient with reduced ejection fraction. It is absent in heart failure with preserved ejection fraction. Now, I have brought to you the 2016 European Society of Cardiology guidelines for acute and chronic heart failure. You will see how they start with in the earlier days. It was a very well studied guideline, but the process of the titration is very slow. They start with ACE inhibitor, beta blocker, up titrate and see the result. If it is still unsatisfactory, go to mineralocorticoid receptor antagonist, and if it is still asymptomatic, then go to other things like ACI or ARB. If they can tolerate ARNI, it should be replaced here. If the patient is sinus rhythm and if the duration is more than 130 milliseconds, you should go for CRT therapy. And if the sinus rhythm with heart rate more than 70, you should go for ivabradine. See how much time it will take. If you go like this, the patient will continue to suffer. Patient mortality benefit will not be seen if we make so much delay in treating. For a simple disease in, say for example, tuberculosis, we give 4 drugs at a time. But why such an important situation, such an important disease, heart failure, we are going one by one, and we reach the goal at the 6 month or more, if we at all we want. There is a class 1 indication in all the 3 treatment here is shown: ACI inhibitor, beta blocker, and mineralocorticoid receptor antagonist. Now, what the current trend? What is the current treatment options we have got in heart failure? We have got ARBs, ACE inhibitors. In ARBs, 3 drugs are very well known for reducing the heart failure mortality: valsartan, losartan, and candesartan. CHARM trial was once upon a time was just a name, and they were all quoting the CHARM trial. But now losartan with the ELITE trial has also shown similar result, and in valsartan, the PRADARINE trial has not used valsartan as such, but it has added to the sacubitril and valsartan together and compared the result with the enalapril and found that it reduces the risk of death and hospitalization for heart failure. So we have got ACE inhibitors now: ramipril, lisinopril, perindopril. They all have shown good response. Now we have got 2 things have come up recently: SGLT2 inhibitors like dapagliflozin and empagliflozin. Dapagliflozin, the DAPA heart failure trial is a very well conducted trial, large number of the patient, and they found that the worsening of the heart failure can be reduced by using this. See, almost similar result was seen with empagliflozin in EMPERAL reduced trial. I will show you the slide of DAPA heart failure trial in later discussion. Now, the mineralocorticoid receptor antagonist MRAs has also proved good. It is especially in improving the left ventricular diastolic function, and spironolactone was used, but in the recent trial they have used eplerenone. The current treatment option then comes the beta blocker. There are only 3 beta blockers which are used in heart failure: metoprolol, bisoprolol, carvedilol. And metoprolol was used in MERIT heart failure trial. It is a very robust trial, large trial, and they have taken all aspects of the heart failure, from younger age group to elderly, to reduced ejection fraction, in diabetic, in non-diabetic, in kidney failure disease, and in very severe heart failure. In CBIS2 trial, they used bisoprolol. They also decreased the all-cause mortality. And carvedilol, Copernicus trial, they also reduced the mortality. So we now see the composite picture of the heart failure trial with meta-analysis. It shows that this is the hazard study, shows that the beta blocker comes in a better position is compared to the placebo or anything. So it is on the left side. The more it is on the left side, it means the hazard ratio is less. So heart failure treatment, we have got fantastic 4 drugs: MRA, beta blocker, SGLT2 inhibitor, ARNI, that is angiotensin receptor neprilysin inhibitor. But it doesn't mean that we are not going to use other things. We must use all the standard treatment. If the patient needs a diuretic, we will add diuretic. If the patient needs digitalis, we will add diuretic. If the patient needs ivabradine because of the persistent tachycardia, we will use ivabradine. And if the patient is having a QRS interval prolonged quite more than 0.130, that means left BB type or non-specific intravascular conduction defect, in that case we will use CRT. So we will use all other things If the patient is anemic, we will give IV ferric carboxy maltose injections. Likewise, we will add, these are the drugs, main drugs, but the entire spectrum has to be used and we cannot ignore those things. The beta blocker is definitely foundational therapy for heart failure. Beta blocker remains the cornerstone of treatment of heart failure. Evidence from recent guidelines, large clinical trials of heart failure. Beta blockers, the beauty is that you can use it in all stages of the heart failure, stage A, B, C, D, whatever, but you must see that the patient does not have a absolute contraindication for beta blockers. Now look at the Canadian guideline of 2021, a very good picture. You see, in one straight line they have put all the 4 drugs, ARNI, beta blocker, MRA and SGLT2 inhibitor, all in one line. But after using it, it means all should be used at the same time. But at the same time, we must assess the clinical factors for additional intervention. As I said before, use other drugs if the patient needs it, and then reassess the situation, reassess the clinical risk, reassess heart failure symptoms, assess the ejection fraction and the benefit. The beta in American College of Cardiology consensus of 2021, they have put 2 drugs in one line, ARNI oblique ACI or ARB, but ARNI they said is preferred drug and the evidence-based beta blocker. So we have to select out of the 3 beta blocker 1. So the 2 should be started together and then we can assess the situation and we will titrate and add additional drug. This is the expert consensus of 2021 by American College of Cardiology. Now beta blockers mode of action. Beta blockers, you know, we have got beta 1 receptor, beta 2 receptor, alpha 1 receptor, and beta blocker differently blocks the different receptor, and there are different functions of the beta blocker, and different drugs have got a different action on the receptor. Like metoprolol is only acting or blocking the beta 1 receptors, bisoprolol also only on 1 receptor, carvedilol on beta 1, beta 2 and on alpha 1 receptors. They act on the beta receptor on the heart, and what is the effect? They reduce the heart rate, they reduce the force of contraction, thus reducing the workload of the heart, reducing the sympathetic activity by acting directly on the pre-receptor nerve ending. These things, by reducing the workload, we are going to preserve the ATP in the myocardium, and it will be cost effective. We will utilize less oxygen when in a compromised situation, when we have got a coronary artery narrowing, so we will conserve the energy and we will use less oxygen supply. Now the pharmacokinetics and pharmacodynamics or beta blockers are very important. We must know when using the beta blockers whether, especially I would say, stress on the excretion point. If you are using say bisoprolol, you must know that it is renal and hepatic 50-50%. If you are using metoprolol, it is purely hepatic. If you are using carvedilol, it has got hepatic 2/3 and 1/3 is by renal. So less balance, but both have got this. This is very important because we have a lot of the patient of the heart failure with kidney disease, with liver problem, and so many things. So we must know it, and before prescribing the beta blocker. And this will not only excretion, but this will tell you the blood level of the particular beta blocker is going to increase tremendously or going to decrease. Clinical studies of beta blocker, it is recommended in multiple cardiovascular comorbidity. B is heart failure, hypertension, ischemic heart disease like coronary artery disease, arrhythmia, and acute myocardial infarction. Metoprolol can be used in all the 5 subsets, carbidopa in the first 3 and bisoprolol again on the first 3. The MERIT heart failure trial is a very robust, well-conducted trial, and it used metoprolol, and it touched all the aspects of the patient situation, like simple, mild heart failure, severe heart failure, younger population, elderly population, diabetic, non-diabetic, likewise kidney failure patient. So we will have a good idea of how it is going to affect the life of the patient. The inclusion criteria, really ejection fraction is from less than 35% to up to 40% they took it, and resting heart beyond 68 beat per minute, and systolic blood pressure beyond 100. These are the 3 important conditions for inclusion. You see the mortality, what happens with the MERIT heart failure trial. That definitely metoprolol brings the curve down to right side in comparison to placebo. So total mortality is definitely improved with metoprolol. See the cardiovascular mortality, again similar result, similar type of the curve you can see. The sudden death, cardiovascular sudden death. Metoprolol reduces quite significantly in comparison to placebo if we take the incidence of the sudden death. Death from heart failure, again it is playing very good role in reducing the death from the heart failure. Metoprolol was also tried in idiopathic dilated cardiomyopathy, which is a very common condition in our practice. Change in ejection fraction, how the use of the metoprolol brought changes in ejection fraction. They took 12 months and they found that there was improvement in the ejection fraction of the patient on metoprolol in idiopathic dilated cardiomyopathy. There was statistically significant. Beta blocker heart failure with comorbidities, diabetes, elderly, chronic kidney disease, post-MI, severe MI. In all such situations, beta blocker was used. See the MERIT heart failure subgroup analysis in diabetic patient. That you see in the diabetic is increased in all-cause mortality. Cardiovascular hospitalization in diabetic patient is increased. Hospitalization for heart failure again is increased in diabetic, and the all-cause hospitalization in diabetic patient is increased. So diabetic is a very important thing to be considered. In MERIT heart failure subgroup analysis, they found that the metoprolol effect brought the hazard ratio to the left side. The more it is on the left side, better it is, less hazardous as compared to the placebo. So that's good news. And regardless of diabetic status, whether the patient is diabetic or non-diabetic, a highly significant reduction in hospitalization for heart failure was observed with metoprolol, CR or XL therapy. That is a prolonged, delayed action type of thing, not short acting formulation. In elderly patient, as the age is advancing, we see a lot more elderly patient than what we used to see 40 years back. less than 65 years, more than 65 years. In both the group, metoprolol brings the favorable effect. Sudden death, again, it is reduced with metoprolol. All-cause mortality is reduced, and worsening of heart failure, it is reduced. So a very significant curve it is showing within elderly population. If you see the analysis of elderly patient, you see that the curve hazard ratio is much on the left side with the metoprolol. Metoprolol was easily instituted. It is safe, well tolerated in elderly patient with systolic heart failure. The data suggests that these are the patient in whom treatment will have to be the greatest impact, as shown by the number of lives saved and number of hospitalization is avoided. Of course, in any group of the patient, some care is required in clinical medicine. You cannot just blindly give the patient and just sleep after that. In an CKD patient, also in CKD patient, it was shown that the metoprolol was effective, whether the eGFR was less than 45 or it is more than 60. In all the conditions, it was effective and better. Heart failure in a post-MI patient. Again, you see the metoprolol has brought the curve down, and sudden death after MI, it has again shown it is a better, very good response. In post-MI patient with symptomatic heart failure, metoprolol continued to exert the profound reduction in mortality and morbidity in presence of contemporary management that includes early and rate revascularization, ACI, and aspirin, statin. As I said, there is no one drug which you will just use it and forget it. If the patient needs other supportive treatment, the first line treatment of the coronary artery disease, the aspirin, statins, or a double antiplatelet agent, DAC treatment, all these will continue. Revascularization, if the patient needs, will continue with either PTCA or CABG. But on top of it, if you add this metoprolol, you will have this effect. In merit heart failure subgroup analysis post-MI patient, you see again the hazard ratio is on the left side, so benefit is very well seen. In severe heart failure patient also, they are shown to be very useful in metoprolol treatment and sudden death. A subgroup of patient with metoprolol XL variety randomized intervention trial in chronic heart failure in New York Heart Association with class 3 and 4. In this group, class 3 and 4 class 3 is clinical heart failure, class 4 is almost refractory heart failure. In such situation, severe heart failure, we have find that the metoprolol is going to be effective, as shown here. Now, other than the beta blockers, I would like to share with you two landmark trials, Paradigm Heart Failure Trial and DAPA Heart Failure Trial. It's worth sharing and knowing it. See the Paradigm Heart Failure Trial. This is the slide borrowed from Professor J.V. McMurray of Glasgow. He is a professor of cardiology and main research person in this group, published in New England Journal way back in 2014 actually. But it was not taken much cared about the outcome. Now they have now come to know that we were late in this study. in this study, they took class New York Heart Association class 2 to 4. It's a large trial, 8,400 patients, elevated NT-proBNP and LV ejection fraction less than 40%. The patient was already on beta blocker, patient was already on mineralocorticoid receptor antagonist, and it was followed for 27 months. Average ejection fraction was 29.5%. With the addition of neprilysin, that is ARNI. ARNI is angiotensin receptor neprilysin inhibitor, sacubitril. It is given together with valsartan due to reasons, quite important reasons, which I will share later on. See, the mortality is decreased by adding neprilysin inhibitor in this group. So this is the paradigm heart failure trial. Now we have got a very good trial of DAPA heart failure trial, very well conducted. Again, Dr. McMurray is the main research worker. Then Dr. Solomon and others, published in 2019 in New England Journal of Medicine. Inclusion criteria: ejection fraction less than 40%, NT-proBNP more than 600 picogram, and stage 2 to 4. Exclusion was when eGFR was less than 30, blood pressure was less than 95 systolic, and type 1 diabetes they excluded. In all these conditions, lot of the patient were on RAS blocker, on beta blocker, membrane mineralocorticoid receptor antagonist, and in this group they added dapagliflozin and found that adverse outcome in heart failure was reduced by addition of this. So it is a very good addition in the armamentarium, and it works by osmotic diuretic. It inhibits in the proximal convoluted tubule, the glucose absorption is reduced to 10%, 80% passes out in the tubule, and it works as an osmotic diuresis, and it is almost working like a diuretic as well, and the mortality is definitely better. So now, ladies and gentlemen, I think I will sum up the matter. You can call it take-home message or the summary. The 5 pillars of heart failure: rejection,